hematology, oncology, pharmacology, alkylating agents. All right, so for our alkylating agents, all of these are cell cycle nonspecific. You don't have to worry about where they're attacking, okay? Perfect. These are relatively easy. They're made up of busulfan, okay? Cyclophosphamide, nitrose, and the last one really isn't as important, but procarbazine. Now, busulfan, as well as all other alkylating agents, the reason they're known as alkylating agents is because they cross-link DNA. When they cross-link DNA, it causes destruction of DNA. So if you see cross-linking of DNA, start thinking about alkylating agents as your number one thing that's on your differential for your answer list, okay? So first off, busulfan, mechanism of action, cross-links DNA. Now, what we need to know is that the adverse effects are pulmonary fibrosis, okay? So remember, the two that are pulmonary fibrosis, one is bleomycin, number two is busulfan, okay? And hyperpigmentation. Okay, so if you see hyperpigmentation on skin, then you know you're dealing with busulfan. Next is cyclophosphamide. It's a nitrogen mustard. Once again, cross-links DNA. And what they love to ask about is that it can lead to hemorrhagic cystitis in bladder cancer. Okay, so to prevent hemorrhagic cystitis, you have to give patients that are taking cyclophosphamide Mesna. Okay, so Mesna is going to be protective against getting hemorrhagic cystitis for patients that are on cyclophosphamide. Lastly is our nitroses, which are carmustine and lomustine. This is cross-linking DNA, but it has CNS entry. So the adverse effects are going to be obviously dizziness, ataxia, and any type of CNS toxicity because it has the ability to enter our central nervous system. All right? That's all for the alkylating agents. So I'm going to move on to our platinum compounds. The platinum compounds, they end in platin. So cisplatin, carboplatin, oxaliplatin, okay? They end in platin. And once again, they cross-link DNA. So just like our alkylating agents, our platinum agents are going to cross-link DNA. They're cell cycle nonspecific, not important to know, but the adverse effects are really important. The first adverse effect that you need to know is that it can cause nephrotoxicity, specifically acute tubular necrosis, ATN. And we're going to get into the specifics of what ATN is, but there's a lot of causes that can lead to ATN. This is one of them, giving platinum compounds for any type of chemotherapy. Okay, we can prevent that nephrotoxicity of platinum by giving them amifostine. Okay, so amifostine is going to be used to prevent that nephrotoxicity secondary to platinum usage. Secondly, it can lead to peripheral neuropathy. And lastly, it can lead to ototoxicity. So be aware of those three adverse effects for platinum usage. Next is microtubule inhibitors. These are all M-phase specific, okay? And there's two types. You have taxanes and vinca alkaloids. The taxanes end in taxol, so docetaxel, as well as paclitaxel. These stabilize our microtubules, okay? And so that means once they're stabilized, they prevent mitotic spindle breakdown, okay, causing the death of the cell. You have to worry about neuropathy. If you see peripheral neuropathy, the first thing that you should be thinking of, not always, but the first thing you should be thinking of are your microtubule inhibitors, whether that might be taxanes or vinca alkaloids, okay? Vinca alkaloids or vincristine, vinblastine, these inhibit microtubule formation, preventing mitotic spindle formation, right? So taxanes stabilize, vinca alkaloids inhibit, okay? Both of them are going to have adverse effects of neuropathy, peripheral neuropathy, so be aware of that. That's a question they love to ask. Okay. Lastly, we're going to be talking about our topoisomerase inhibitors. Topoisomerase inhibitors, you have irinotecan and topotecan. These end in tecans, okay? And they inhibit topoisomerase 1, okay? The adverse effect is diarrhea. And then we have etoposide or tenofoside. They end in poside, and they inhibit topoisomerase 2. The adverse effect is alopecia, okay? These are specific for S and G2 phases, and they're really not that high yield. They don't really like to question much about them. Lastly, I'll cover tamoxifen. However, I'm only going to be covering it in a small period because in the repro section, tamoxifen is covered in much more depth, but it's a SERM, okay, which means it's a selective estrogen receptive modulator. Okay, all that means is that it's going to be selectively targeting our estrogen receptors. And it can be an antagonist at some locations and an agonist at other locations. So it's an antagonist at breast tissue, hence why it's very good to be used with breast cancer. But it's a partial agonist in the endometrium in the bone. So we have to be careful about giving tamoxifen to patients that have breast cancer. We have to make sure that they don't get endometrial hyperplasia because it is an agonist at endometrium and it can lead to endometrial cancer, okay? Overall, I'm going to stop right there and we're going to probably do anti-cancer monoclonal antibodies as a separate section.